Good morning, everyone. It's my pleasure to welcome you all to Chicago and Heart Rhythm 2026, the 47th annual meeting of the Heart Rhythm Society. If you have not already done so, please download the HRS 2026 mobile app from your preferred app store. This is how you can participate in live Q&A sessions. When using this app, log in with your HRS credentials. Please note that visual reproduction of Heart Rhythm 2026, either by video or still photography, is strictly prohibited. Thank you and welcome. Our first speaker is Dr. Robert Schaller from the Hospital of University of Pennsylvania, and he's going to give us a presentation on diagnosis and treatment of implantable devices-related edema.
Good morning. Thank you to the chairs and my co-speakers. Okay, so I'm going to be talking about the evaluation and management of lead-related peripheral swelling or peripheral edema. So venous stenosis is incredibly common after lead delivery. It could be subtle, 5%, 10%, or it could be dramatic. The entire vein can be occluded. But symptoms are very rare. Sometimes it's harder to get new leads in, but someone with swelling, encountering someone with swelling is relatively rare. And there's two ways that this could happen. Venous thrombosis. That is generally an acute event. A patient develops swelling shortly after their device goes in. It's dramatic. You start them on blood thinners, and usually they get better actually quite quickly, especially with heparin. Not really a big problem. You could stop their blood thinners after a month or so. But venous stenosis is a bigger problem. That's really more of an inflammatory reaction of the intima of the and the endovascular portion of the vein, and that can occur usually months to years after implantation. And it's generally refractory to oral anticoagulation unless there's a little bit of both going on. The problem with venous stenosis and edema is that the pressures in the tissue can increase because of the edema, and that can lead to lymphedema, problems with the lymph system, and that can be somewhat irreversible. So affected regions are typically the arm on the side of the device, unilateral neck. This is not appreciated very much, but right over there on that top portion of the neck, you can get some swelling. That's usually due to this venous webbing collateral system that's present. It could be both sides of the neck. That's what we call SVC syndrome. That tends to get more red in color. But the arms and the neck tend to have a blue or red speckled appearance. That's how you can tell if a patient has a little bit of developing a little bit of lymphedema. So regular edema or traditional edema is pitting. It's uncomfortable, it's dark, it's gravity dependent, and if you push on it, you can make a big dent. The difference between that and lymphedema is that lymphedema is non-pitting, it's puffy, it's light speckled blue pattern, it's non-gravity dependent, and it's painless, but it can be very annoying, and there's no good way to treat it. So if a patient develops peripheral edema, what we do at Penn is we start them on a blood thinner very quickly, and if this doesn't resolve within 30 days, we do prompt venography and venoplasty. I almost treat it as an emergency. Get that patient in within 30 days because, one, it's easy. It's easy to do a venogram or venoplasty, and two, time really does matter. So when we bring them into the lab, we'll do a venogram with 20 cc's, always 20 cc's at least from the side of the device, and you could almost always see where the occlusion is. Sometimes it's a complete occlusion, sometimes there's some trickling of contrast that gets through, and it's easy to do it from the SVC as well through the right IJ, and sometimes it's completely occluded. You have to do it from below to see where the occlusion is. And if you're going to do a venoplasty, which is very easy, and you don't have to open the pocket, you could do it from the chest or the right IJ, you could even do it from the groin. You can first cross with a hydrophilic wire, and it's quite easy to do. You could generally cross at least 2/3 of these cases. Here we're using a hydrophilic wire with just a small little dilator sheath that gives you a little bit more maneuverability and backing. If that doesn't work, sometimes you can even cross with catheters that are hydrophilic. This is just a hydrophilic catheter that we're navigating through this occlusion, and then of course you advance the wire. So you get better at crossing these occlusions as you do more and more of these. Now, if you can't get through the occlusion, you're going to have to perform a lead extraction, and you can do that traditionally with laser leads or mechanical sheaths or mechanical sheaths, but sometimes the lead moves back and forth and you have to grab it from below and hold it there while you're pushing the sheath through. It's quite hard. So one thing that we've noticed over the last couple of years is that these don't occur at year 12, at year 20. They usually occur at year 2, 3, 4, 5, something like that. And we have a nice retained wire strategy that works quite a bit, and that involves leads that are freely mobile. So if a lead is under 5 years old, almost 90% of them can be pulled directly off the myocardium. You might have to pull a little harder than you're used to, but it will pop off, and it's no riskier than putting sheaths in. Once you have that lead that's freely mobile, all you need to do is cut the back end of it, put a whisper wire down the lead, snare that lead from below, and then pull it out of the groin. And then by definition, the lead is out, and the wire is traversing the area of stenosis. So no better lumen to start venoplasty than the true lumen there. So this has bailed us out of about 75% of these cases did not have to open up a laser sheath. We use two different types of balloons, a regular, what I call a regular non-compliant balloon, goes up to like 10 atmospheres, and then a high-powered non-compliant balloon goes up past where your insufflator will even take you. I think you could put your car on these balloons. They're so non-compliant. And we're moving more and more towards the ultra non-compliant balloons because sometimes, or it's very common to find that these are napkin ring lesions that require a lot of power to open them. Always start distal when you're venoplasting because you might not be able to get back distally. And if you find that the balloon is being forced distally, that's called watermelon seating. It means that your occlusion is behind you. So all you need to do is pull back a little bit and open up, and you get this nice, satisfying napkin ring lesion that usually pops open with these balloons. And then never think that that's enough. You always have to map behind you as well. You probably see it with the venogram, but even if you just blow up the balloon behind you, there's no harm, and there's almost always another lesion between the first rib and the clavicle. This patient had neck swelling, and she had a nice focal lesion here with the collateral webbing seen. So we cross this lesion with a hydrophilic wire and a catheter. We do local phenography. It gives you a bit of a better, more granularity to the where the lesion is. We're going to open it up with our non-compliant balloon. But then we're going to notice that we probably undersized our balloon. So what we're going to want to do is look at how big the vein is before and after the occlusion and use that size balloon. So we said we undersized, let's go to a bigger 10 millimeter balloon and fully open it, and she had a nice response. We do this just from the chest. You could even do it from the brachial vein if you want to. It's more like a cath way to do it, but we like doing it from the chest. And she had a nice response. Treating the SVC is even easier. You don't have to get access in the chest. You do everything from the right IJ. So here's our venogram showing where that occlusion is. It's almost always a couple of centimeters below the azygos, and it's almost always focal. Here's our local venography from the right IJ. We're going to venoplasty. You basically get the biggest balloon that you have in the hospital. I don't think they make a balloon that's too big for the SVC. You could certainly go up to 14 millimeters. And the flow is restored. It's very nice. So we did this prospectively with these types of balloons in 18 patients, 27 procedures, and we learned that the edema always goes away. The vein's open, so the arm trains. We found that lymphedema never goes away. We didn't even know what lymphedema was when we were doing this. So there could be three possibilities of outcomes. You could have complete occlusion. That means the patient had 100% edema. You could have partial improvement. That means they had a mixture. Or you could have no improvement, which means that the arm was probably puffy and it was pure lymphedema. In our study, 72% of patients had complete resolution, 22% had partial, and one patient had pure lymphedema. Interestingly, if lymphedema remained partially or completely, those patients were associated with a longer time between the diagnosis and the procedure. So there's a time, this is a time-dependent phenomenon, and this is why we approach these patients so aggressively. Now, long-term follow-up, if all leads were removed, you're cured. There's an incredibly low chance that that vein is going to restenose, as long as you keep all of the leads out of that area. But if the leads remain across the occlusion, 2/3 recurred. So that was a big problem. You could see how many patients recurred here. Some of them required multiple procedures, and not all of these patients had leads crossing the occlusion. So only the patients that had it. So 2/3, not so great. So we started exploring this drug-coated venoplasty balloon, thinking maybe we could open up with the balloon and then the paclitaxel will keep the vein open. And this is what that looks like here. We're treating a patient with SVC syndrome, balloon venoplasty with a traditional balloon. and then a chef's kiss, as you were, with a drug-coated balloon after. You keep this one up for 3 minutes so it has ample time to elute into the surrounding area. And if there's multiple lesions, you treat it with multiple balloons, and then that's it. It's the same thing. The vein is now open, and we're hoping that it's going to stay open. Well, we did 14 patients like this with 17 procedures. We found that 86% had complete resolution, 7% had partial improvement, and 1 patient had just lymphedema. But only 29% of the patients recurred with leads that are crossing the occlusion compared to 66. You can see all of these patients, we started getting really good at crossing these lesions, so not having to remove the leads. So almost all of these patients still have leads across the area that was affected, and only 2 patients required repeat procedures. And after the second and third procedure, these patients are okay as well. So this is a rate of a single procedure recurrence rate. So we're getting much better results, and this is now our standard of care. So we've proposed an algorithm for patients that present with peripheral edema post-CIED. And if you think it's related to the procedure, then initiate oral anticoagulation right away. Heparin's probably the best. Warfarin's probably excellent, but pragmatically, we just start a DOAC. And if they get better within 30 days, great. Continue it for 3 months, somewhat of a made-up number, but it seems reasonable, and then just monitor for recurrence. If they don't get better, prompt venography and venoplasty. We prefer with a drug-coated balloon because our results are better, and consider removing everything if you have a leadless option. That would be ideal. If you can remove everything, they will get better. You can keep them on oral anticoagulation for 3 months, and you can monitor them, but they should be essentially cured. If they don't get better, or if you can't remove all of the leads, then you have to see what happened with the long-term results. If they have complete resolution, then the diagnosis was edema. You could anticipate a possible recurrence. You could think about giving them anticoagulation long-term, but we just don't know how effective that is. And if they recur, then you have to think about taking the leads out. If they have a partial resolution, the diagnosis was edema and lymphedema, consider removal of all leads at that point, because you really just don't want to mess with lymphedema, and refer them to a lymphedema clinic where all they're really going to do are give them sleeves and compression devices that keep the symptoms at bay, but in no way cure that. And if there was no resolution whatsoever after venoplasty, then the diagnosis is lymphedema. This is very unfortunate. Consider removing everything as not to worsen the situation, and refer that patient to a lymphedema clinic promptly. Thank you very much.
Thank you so much. And I know we already have some great questions coming in, but we'll wait for Q&A after our third talk. Yeah, halfway through. All right. Next up, we actually have Dr. Mella up for the Thank you. Sorry about that. To discuss lithotripsy assisted lead extraction.
Great. Good morning, everybody. My task today is to talk about intravascular lithotripsy to assist lead extraction, and really to try to answer the question of whether this is a technique ready for prime time. My disclosures. And I will talk a little bit about lithotripsy in lead extraction in some more extent, and I will share with you one of our cases. So lithotripsy is something that I always had at the back of my mind as the technique of choice for treating kidney stones. A few years back, our interventional cardiologists started using lithotripsy for peripheral arterial disease, and that was something that reportedly was making their life much easier when they had to cross long calcified lesions. It was not until some recent publications that I will discuss with you that we became a little more familiar with that system for peripheral arterial disease in the management of lead extraction. So this is the case that I would like to share with you, a 37-year-old woman who came to me, was referred to me because she had received an ICD 20 years before when she had sudden cardiac arrest in the setting of arrhythmogenic mitral valve prolapse. Her right ventricular lead is obviously dual coil, as you can see here, and has started showing some signs of getting older. And she was at a point of her life that she wanted to fix her mitral valve prolapse with severe MR and take care of the defibrillator because she wanted to start a family afterwards, so she wanted to have a new start from a cardiac perspective. So when I deal with these very old leads, the first thing that I tell the patient is that many times is very hard or impossible to pull out. And this was my stand until the recent past, when the first publication on shockwave intravascular lithotripsy came out in 2023 by these two authors in Minnesota. They used the same balloon that our interventional colleagues use to cross and or treat after they have found difficulty extracting leads all along the course of the leads, trying to address areas of calcification and potentially make the extraction easier. So they used it in 14 cases. Using the system was quite safe, and they were able to extract all the leads. Actually, in an editorial in that same issue of JACC in 2023, we learned a little bit about the mechanism of how lithotripsy works in general. So what happens, there is an electrical discharge that vaporizes fluid in the balloon, which then creates a rapidly expanding and collapsing bubble that generates acoustic shock waves, which you can hear at the time that you apply. And to make it clear, this was an FDA-approved device back in 2016, but only for peripheral arterial disease. There was also, around the same time, a publication, a case report on a patient with a 30-year-old dual coil lead with the additional information or way of managing these patients with a CT before, so to really clarify where calcification could be, and also using intravascular ultrasound to confirm where calcifications were, so to know where to go and apply the shockwave therapy, and also size the balloon, because the balloon, we can have three options of an 8 millimeter, 10 millimeter, or 12 millimeter diameter balloon. So we started using reluctantly shockwave in some of our cases, and this was a publication from our institution. And in the picture, this is a patient with dual coil ICD leads from 1992 and 2003 that obviously were successfully extracted, and that's why we reported. And also one novel use of the balloon to remove a retained fragment of an atrial lead that was stuck in the SVC region of an old atrial lead that not even the surgeon could remove during surgery. So we went back and we were able to snare successfully after we had applied lithotripsy. And finally, just this month, a report from Vanderbilt where they used lithotripsy in patients before they had even accessed the leads and tried to extract. So pre-treating the patient before even the extraction started in 49 total leads, with the longest dwell time of a mean dwell time of 16 years, with very good results by only using laser extraction sheath and only in 12% additional mechanical sheath, and they were successful in the majority of the patients without complications. So I took this path for this particular patient, and this was her fluoroscopy before we started the procedure. And so what you need to do, and we do it, I do it mainly from the right femoral vein. You put a balloon, 0.018 catheter first, and you go as distally as you can, and then you go up with the balloon. I have used mainly the 10 millimeter balloon so far, and you successively deploy the balloon, apply the shock waves. Every balloon can only deliver a certain amount of applications, 10 applications of 30 pulses. So what you do, you successively deflate and inflate the balloon, and you perform the shock wave in the areas that you think that you have the best contact to the area that you want to address the calcification. The radius of effect is 5 to 7 millimeters, so applying shock wave in areas where the leads are further away is probably not helpful, although another technique can be to use deflectable sheath to bring the balloon close to the leads where you think most of the calcification is. So with this patient, after we did the lithotripsy, we went with mechanical sheaths, and we successfully extracted both the leads. I would say much easier, and again, without a control for this particular patient, but you have the sense that the extraction becomes easier after you pre-treat the leads. So successful extraction, reimplantation of a dual chamber ICD. Her preference was to stay with the transvenous system, and 2 days later, actually, she also had a minimally invasive mitral valve repair and PFO closure, and she's recovering well at home. So conclusions, thoughts, directions. These are very preliminary data that show that using the intravascular lithotripsy as an adjunct for lead extraction for calcified lesions appears to be safe and efficient. But some thoughts around the areas that we don't know. An area that requires additional evaluation is the potential impact of IVL, that the impact on active leads. So far, we have used it in our center for leads for systems that would come entirely out. We have not used it when we were planning to leave leads behind because they were still working well. Also, we know that it works well to affect the calcification that exists between the lead and the wall of the vein, but we don't know if there are 2 or 3 leads and calcification in between them, how successful it can be. And finally, also, we don't know what the optimal settings, and we need to know more about patient selection to really know that this methodology is safe and effective for successful procedures. Thank you for your attention.
Thank you, Dr. Miller. That's an excellent outcome for the patient. Our next speaker is Dr. El Chami from Emory University. He's going to talk to us about how leadless pacing is reshaping lead management strategies.
Thank you for the introduction and the invitation to be part of this session. It's hard to follow Rob and Dr. Mela, but because they had an amazing presentation. When I was assigned the topic of how leadless pacemaker is reshaping lead management strategy, I wasn't sure what I was going to discuss, so I did what my 13-year-old does, which is ask ChatGPT. And it really gives me an amazing outline, so I decided to follow most of it. So if you don't like it, blame ChatGPT. When it comes to medicine, prevention is often better than cure. And one of the ways to prevent complication is to minimize the number of leads that you implant and choose the appropriate leads that down the road will not generate a problem if you're trying to extract them. And the guidelines that were, the Heart Rhythm Society lead management guideline that were published yesterday, and there's a nice session today in the afternoon if you have time to attend, really had a specific section about implant technique and lead choices to minimize future problem with lead extraction. For those of us, including me, who when you put a primary prevention ICD and you add an atrial lead, think twice about the necessity of the atrial lead, for example. But really, the ultimate lead management strategy is to completely avoid leads if possible. I think about it in patients referred for de novo pacing as a primary prevention lead management strategy. And the committee on the guideline acknowledged that and used this class 1 recommendation in patients who require bradycardia pacing support. There should be a shared decision making to choose the pacemaker type based on a patient-centered approach. While this algorithm didn't make it into the guideline, it really summarized the spirit of that recommendation. If you have someone who needs a de novo pacemaker, you should sit with the patient and discuss the pros and cons of all the pacemakers you have. And based on which you choose transvenous versus leadless. Obviously, there are factors that favor leadless. You know, if you have a preserved EF, you don't expect to RV pace, or the common ones like infection risk or vascular access limitation, then leadless pacemaker should come to mind. And even if you decide to choose a leadless pacemaker, you should think about pacing using the modular approach to minimize intracardiac and intravascular hardware. And that has become more common in the era of leadless pacing. And I will discuss our experience briefly toward the end of this talk. So if you have sinus node dysfunction, there's nothing wrong with choosing an atrial leadless pacemaker and just minimize the number of hardware in the heart. And the reason the committee reached this decision of a class 1 recommendation for shared decision making is not only to minimize lead, but it's based on studies. Mind you, we don't have a randomized controlled studies, but we do have large prospective registry. And all of these registries have a common theme, which is a reduction in intermediate and long-term complications when you compare it to historical cohort of transvenous pacemakers. I will share with you 3 or 4 trials, and you can see that the KM curves looks exactly the same. The first one is the MICRA CED 2-year follow-up. Enrolled Medicare patients, 6,000 leadless, 10,000 transvenous, obviously not randomized, but people in Medicare patients receiving leadless versus single-chamber transvenous. And you see nearly 40% reduction in reintervention. And when we discuss reintervention in the context of a transvenous device, we mainly basically reintervening to fix a lead and to a lesser degree fix a pocket. The same results, the MICRA AV CED 2-year follow-up study. Again, 40% reduction in intervention, and we have here 7,500 leadless and more than 100,000 transvenous devices. More recently, the AVIR VR CED study was published. You have around 2,400 leadless and 20,000 transvenous, and you see here 60% reduction in intervention, which translates into nearly 50% reduction in complication. The longest follow-up study we have is the post-approval registry, 5-year follow-up. Again, it mimics the prior. These KM curves look so much the same. So even though it's not a randomized study, the signal seems to be real because it's a repetitive finding in all the large prospective registries. And one of the ways to minimize reintervention is obviously minimizing infection. And infection, as you all know, is the #1 indication for lead extraction. And in the post-approval registry, there was 1,800 patients followed for 5 years. None required demise removal for infection. Shifting gear to talk about modular concept of pacing with a leadless system, I'll show you here our experience so far with Avere. Nearly 180 patients, 99, so 55% of those are just single-chamber atrial leadless device. 30% single-chamber ventricular device, and 14.5% dual-chamber leadless device. And we've shown the early experience where there's 1 out of 60 or that required upgrade to a dual-chamber device. And you think about it in a modular way where down the road, if you develop heart block and you have sinus node dysfunction, you have an atrial leadless, you could upgrade to dual. And if you have a leadless AV and you develop sinus node dysfunction, you can upgrade to a dual chamber. So we talked about how leadless pacing can reshape lead management strategy in patients referred for de novo patients, but eventually these leadless devices will need to be managed down the road. And the new guidelines, led by Dr. Cha here, gave Class 1 recommendation for certain areas where these devices need to be removed, i.e. proven infection of the device, something we can talk about later in questions. But I guess the most controversial one is when to abandon versus when to extract when you hit EOL at time of upgrade. And here, shared decision-making is a Class 2A. Obviously, fresh device, you need CRT upgrade after 4 months, might make sense to remove it. 10-year-old device, you probably just can leave it, especially if it's a ventricular device. So I showed you how leadless pacemaker can reshape lead management strategy in patients with de novo pacemaker. But I truly believe that leadless pacemaker can reshape lead management strategy in patients with pre-existing leads. And I called it secondary prevention lead management strategy. And I could think at least of 3 scenarios where there's a role for leadless devices to minimize risk of extraction or opening a pocket. Number 1, patients with malfunctioning transvenous leads, patients at high risk of lead failures, or patients with infected CIED. These are 2 examples. The first one, where on your right, this is an 87-year-old with multiple leads, all failed. You're seeing him for the first time. You didn't put any of these leads, but he's 87 now. Probably the time to extract these leads were at the time where you needed to add another lead maybe. But he's 87, frail. Do you want to open the pocket, expose him to an infection? Do you want to add a lead on top of the 4 that he has? Do you want to extract a lead that's 15 years old? I think an elegant and simple solution is a leadless pacemaker. Give him another 10 to 12 years, and then if he's alive at 99, you'll deal with it. And here on this second X-ray, you have a 55-year-old with complete heart block who's had leads dating back to 1985. All veins occluded, all lead fractured, was managed with a dual-chamber Avere. Not optimal given the age, but was doing great until the physician decided to open the pocket and remove the generator. A long story for another day. The second case scenarios is patients at high risk of lead failure. We'll hear from Dr. Shah about TTVR. In the case you accepted jailing a lead, maybe one way to manage it is put a backup leadless pacemaker, because sometimes you want to accept jailing a lead. Pacemaker dependent with recalled lead. If the lead is at high risk of failure, okay, you have the option, open the pocket, add a lead, or extract the lead and put a new one that's not recalled. Or if you're very concerned, you don't want to open the pocket, put a leadless system in. The last, but I think the most useful way where a leadless pacemaker have reshaped lead management strategy is patients with infected CIED, and Josh will be talking in more detail about this, but one of the ways to manage this is extract and put a leadless pacer. There's now more than 40 publications on the literature on this. It's always good to mention Larry Epstein's group because that's the first group that published on concomitant leadless in the context of bacteremia and fungemia, putting a leadless when extracting a device. I don't do this in my own practice, but it's been described. So the committee gave a class 1 recommendation in patients who are pacing dependent and undergoing CID removal for infection. Implantation of a leadless pacemaker during or after CID removal is useful to reduce the risk of recurrent infection. So in conclusion, leadless pacing is reshaping lead management strategy by avoiding leads in de novo pacemaker implants, primary prevention lead management strategy, by providing an alternative simplified solution in case of lead failure where you want to avoid lead extraction or redundant leads, and by providing a system, quote unquote, resistant to infection and a shorter time to reimplantation post-transvenous lead extraction of infected CID. Thank you.
Thank you so much for that thought-provoking talk, and I think that perspective of thinking twice before we put in leads and realizing the consequences we face in long term is a really important point. For the audience, if you haven't put in your questions yet, please go ahead and do that, and you can also come up to the mic and ask questions directly to the speakers if you'd like. I'm actually going to get started with a question I had, I think leadless is a great option, and as the technology is getting better, we have more options. But how do you balance the risk of pacing cardiomyopathy in this age of now conduction system pacing with leadless? How do you make that decision for patients who might need a dual chamber?
Yeah, I mean, I think if I touched a bit about it, if you're expecting to have low percentage of RV pacing, you have a preserved ejection fraction, I think thinking about leadless is, in my mind, I'll go first to leadless.
Mm-hmm.
If I have a borderline EF and I expect the patient is going to pace, then you have to put a conduction system pacing or a CRT. Maybe in the next few years we'll have a conduction system pacing leadless device, but that's how I approach. I think when I think about all my patients referred for a pacemaker, a big chunk of them, they're not going to pace in the RV, or they're going to pace less than 30 or less than 20%.
Great talk so far. My question actually is about lithotripsy. So I have maybe regretted using a certain size lithotripsy balloon because I felt like maybe in retrospect it was too small. Do we think that it's possible to use one that's too big, or is just using the biggest one fine every time?
Thank you, actually, for asking this question, because I would like for all of us to share experience, and sharing your experience is important. So I am always the person of the midway, so I go with a 10-millimeter balloon, and then you decide on how inflated the balloon is depending on the size of the vessel. So when I'm in more distal, like subclavian, even innominate, I would use 2 atmospheres, and as I come down to the SVC, I will use 4 atmospheres. I think this is an area that we need to know more. Opening an IVUS for every case makes the case a little less cost-effective, but this may eventually be another way of knowing exactly how to size the balloon. I should also say that the use of lithotripsy adds about $3,000 to every procedure. We shouldn't forget that. So opening different size balloons also becomes a little questionable in terms of the cost and benefit. So again, in summary, I use the midline approach, and because we are in the early days of using it, I prefer to stay on the conservative side rather than becoming very aggressive right from the beginning.
Thanks.
Thank you. There is an audience question for Dr. Schaller. When you snare lead from below to retain access across stenosis, how is the whisper wire secured to the lead, and do you use a locking stylet?
Yes, you can't use a locking stylet because the lumen can only accommodate one, but if the whisper wire goes all the way down to the tip, so it's quite secure. But you want to snare the lead at least 3 to 4 centimeters proximal to the tip, and that will do two things. One, that will lock the whisper wire, and two, that will allow the lead to turn on itself, fold on itself, in order to come out of the venotomy site very easily. So sometimes the whisper wire will also come out of the venotomy site, and then you have complete control of that wire. You could hold it there if you need to, or it just falls out of the lead while you're taking the lead out, but it's already past the occlusion, so it doesn't really matter.
Thank you. And I have a question for you. SVC occlusion seems like venoplasty is preferable to stenting. Is there at any point that you favor or make a decision to stent? And also, how do you manage anticoagulation long term?
Yeah, I don't think stenting veins is a very good idea unless you're forced to do it. These patients seem to do very nicely with venoplasty, particularly in the SVC. And if you use a drug-coated balloon, I think that's the first way to go. Ultimately, if they recur, you need to find a solution that doesn't include a lead down the SVC. And if you do that, and you remove the lead, do another venoplasty, that patient is going to be absolutely fine. Of course, if they then recur, which is incredibly rare, you can consider a stent. I guess there are scenarios where you truly need leads in that patient, and if they recur after one venoplasty, I think Dr. Alchami has written about this, a reasonable solution would be remove the lead, stent the lesion with the shortest possible stent that you can get away with, because we've seen these long stents migrate, and then put the lead back in through the stent. I think that probably compromises the safety of that lead long term, but I'm not sure.
Can I add something to this? Because we have a little different experience, and we usually share these cases with either interventional radiology or vascular medicine, and they feel quite strongly about stenting veins because veins tend to recoil. So I am impressed and happy to hear your results, that you have good long-term results, but in the few cases that we just tried balloon angioplasty, the patients did come back. Most of these patients have complex systems of CRTD, or they're pacemaker dependent and they get 100% ventricular pacing. So up to now, we're kind of forced to reintroduce leads. So for those patients that you extract leads, deal with the venous stenosis and reimplant leads, I have the feeling that the safest and maybe you have one shot and you take your best shot is to extract, dilate, leave a stent, and then reimplant. And this has been our approach.
Yeah, I think we have similar experience, but I have to say I've never used the balloon-coated drug, so maybe that will change our experience. But if in those who remove the leads and never reimplant, I think balloon angioplasty is great. Recurrence may be a little bit low, but it's acceptable. But if we're going to keep leads there, our experience with at least SVC syndrome, that the recurrence rate is quite unfavorable. But maybe, so what we do is we extract, put a stent, put a lead through it. But now, after hearing Rob, I'll probably use drug-coated balloons and see.
Hello. I'm a surgeon. There's probably not many surgeons here, but just as an extreme, there are patients that are extremely symptomatic, younger patients in particular, and although extreme, surgery is an option, and you can do a superficial vein from the leg and reconstruct the superior vena cava. And I don't know if cardiologists are aware of that, so I just thought I'd bring that up.
Yeah, we've had two cases of refractory symptoms. One SVC, where they completely restructured the SVC with something, but the result was unbelievably great and cured. And another patient that had, the only patient that ever recurred with leads after leads had been removed between the clavicle and the first rib. She had like a thoracic outlet syndrome, and ultimately that vein needed to be reconstructed, and the first rib needed to be removed, and she similarly was cured. So I truly believe surgery is perfect for these patients. It's just a lot.
It's extreme, yeah. And then in general, surgeons don't like stents in the veins. I mean, they tend to recur. So,
Thank you.
Thank you so much. And I know we have some other interesting questions, but we'll try to get to them at the end. We want to keep going with our talk. So next up is Dr. Cooper, who's going to be talking about reimplantation after infection, timing, and site selection.
Thank you. There it is. Okay. So there are a couple main points that I will conclude with at the end that I want you to take away from this. One of the big problems with this topic is there are really no randomized prospective trials to look at such things. When do you reimplant, and comparing an early versus late reimplant strategy. So what we're really stuck with is case series and people's experience, which is very valuable, but just bear in mind that these are not mostly randomized data. I wanted to start by thinking about the principles of thinking about reimplantation after infection. And the first, of course, is to use a new site for the new device implant. If there is infection in the soft tissues of the pectoral area, you don't want to put a new device there, at least not for several months. There are some anecdotal experiences, including some of my own, where I have implanted at the same site 3+ months later, and it has done fine, but in general, we don't wait that long. So look for a new site. You also want to minimize the risk of the device exposure to recurrent bacteremia, and that can take several forms. First of all, if there is no bacteremia in the first place, because you're dealing with a local infection of the pocket, then the risk of reinfection if you go to a new site is very low, and we'll review that. There's also a declining risk of reinfection if you have a bloodstream infection in the first place and you're treating with antimicrobial therapy. Then every day, every week that goes by, the likelihood of recurrent bacteremia is lower, and therefore waiting longer is a good thing. But of course, we run into problems with pacer-dependent patients or those who are device reliant, such as CRT pacing, etc. You have to think also in planning other sites of infection. If there is another foreign body that is infected, if there is another place that's harboring infection, that must be addressed, or you're going to have a higher risk of recurrent bacteremia. And vegetations are likely one of these harbors of infection. You have material there sitting in the heart itself that likely continues to house bacteria, and therefore a longer time to reimplant is likely needed if you want to minimize the risk of reinfection. And then lastly, the question of exposure of the device to the bloodstream. You have subcutaneous extravascular device options, which keeps the device out of the bloodstream in general, and those can generally be reimplanted sooner because you don't have anything in the bloodstream itself. And we'll also talk about leadless devices where the bloodstream component is of smaller surface area and metal versus other substances that are more likely to have bacteria adhere. I think when we thinking about a device extraction, you need to plan ahead for what's going to happen afterward. And some of that is what type of device will this person need in the immediate term and in the long term. Of course, patients who are pacemaker dependent or pacemaker reliant, you need to come up with a temporary solution. And then the question is, what is the patient's longer term device needs? And that is very frequently not the same as what they have had to date. I love this study because it reviewed 302 patients undergoing extraction, and they looked at what the patient's device needs were after the extraction, and only 41% of patients actually needed the same type of device. 23% needed a different type of device, and 37% didn't need any device at all. That's important to think. This is always a decision point when you're taking things out, to think again about the patient's situation. Has it changed, or what was the original indication? Because here, 45% of these 37% of patients had a loss of, they no longer had the indication. For example, somebody with paroxysmal AFib who's now permanent and sinus node dysfunction is no longer an issue. 27% of these patients who no longer needed a device actually didn't have an indication in the first place, so rethinking the original implant indication is critical. And the others were a mixed bag of the patient's preference, or older patients, or persistent infection. This is an important point, and we'll get to a big takeaway from this talk about access sites. You have to think about where you're going to put the new device in before you take this one out, because you don't want to find yourself stuck having taken something out and say, oh, wait a minute, I actually don't have a new place to put the new device. So that must be a part of pre-procedural planning. You have to think about other interests from other specialists, as we'll talk about. Is the contralateral vein occluded? Do they have an access port? Are they a dialysis patient? Are there other devices? They may not be occupying the vascular space, but they may be occupying the infraclavicular space, such as sleep apnea devices or Parkinson's devices, or the CCM device on the contralateral side in our field. Has the patient do they have a relative contraindication to unilateral access, such as previous extensive lymph node dissection? This is a relative contraindication, not an absolute. And also, is there potential in the future for dialysis, and do you need to consult with your renal colleagues about who has the right to the contralateral side in the future if they anticipate maybe needing it for dialysis? And again, you have to think about future bacteremia risk when you decide what access site to put a new device in, including keeping it out of the vascular space altogether. Here are some examples of patients who have crossed my path over the years. The patient on the left has 2 Parkinson's stimulator devices in the pectoral area, which can complicate our job of reimplanting a device. You can see there is a defibrillator that was accessed via the left subclavian or axillary and tunneled down to a lower pocket site. And on the right, you see somebody who has a port. You have to assess whether the patient continues to need a port. Sometimes the chemotherapy or indication for the port has passed and it's just still there. And sometimes that can be removed, giving you access to a site that didn't look available. When I think about implant locations, I think about intra versus extravascular sites, and this is sort of just kind of a guide map as to what are our options. Of course, there's the infraclavicular space for transvenous systems. That's the usual place. Occasionally, we think about iliac or femoral devices, although that can be technically very challenging, and there may be lead longevity issues since you're near the hip flexor area. Of course, leadless devices are intravascular, but you don't need venous access because there's no leads. In the extravascular locations, you have the sub-Q and EV-ICD with a lateral thoracic pocket, and you have surgical devices where you can put in an epicardial leads and a device usually in the left or right upper quadrant. But I want you to consider another option that's not listed here, and that is this lateral thoracic approach. If somebody needs leads, but both of their infraclavicular spaces are occupied because of infection or other devices in place, I want to highlight this option because people may not be aware of it or consider it. Here are 2 patients who had devices put in a lateral thoracic pocket, and I'll show you the technique in a moment, and getting up to the axillary vein for lead access. On the left side, the device pocket was tunneled just behind the pectoral muscle anteriorly, and then on the right side, you have a lateral thoracic pocket. You can still see some air. This was a fresh implant, so you can see a little bit of air in the subcu tissues that then subsequently, of course, was absorbed. This is our publication just talking about this approach and this technique where we, instead of looking at the typical pocket location up here infraclavicular, to go down and make an incision that's vertical really near the anterior axillary fold and making a pocket either on that lateral thoracic space or tunneling it anteriorly underneath the pectoral muscle. The technique I've used that tends to work well to access the axillary vein is to instill contrast into the arm and don't flush it through, but just let it dwell. That will allow you to visualize the axillary vein, and you can puncture it with the needle, and you know where it is. The problem is there's so much variability in the location of the vein, and it collapses very easily. So if you didn't have the vein highlighted so that you can see the indentation and knowing that you're in the vein, you could go through and through multiple times and not realize that you're in the vein. You can create a local hematoma that can collapse the vein, and it can be sometimes difficult to obtain this access from a lower thoracic point. And then you, of course, thread a wire, which you can then double or triple wire rather than having to do repeated punctures. In terms of the reimplantation timing, Typically, in a perfect world, you'd wait till the infection was completely gone. You'd wait for the 4 to 6 weeks of IV antibiotics. You'd recheck blood cultures, confirm that infection is cleared from the blood, and then reimplant. But of course, the problem is patients often need device reimplantation sooner. And so the general consensus, based on no randomized trial data, but rather expert consensus, is to wait a minimum of 72 hours of negative blood cultures before implanting something back into the bloodstream. And if there are vegetations because of valvular endocarditis, the expert consensus in multiple guidelines suggests to wait 2 weeks before reimplanting. Here is not a randomized trial, but an observational study of 109 patients with endocarditis and vegetations, looking at the outcomes of implanting a new device before or after 2 weeks. And they found that there was an increased survival, better outcomes if you in fact waited 14 days to reimplant, and this is where some of this expert recommendation comes from. Of course, these patients have a longer hospital stay that has to be balanced with the anticipated outcomes. In terms of how you bridge patients while you're waiting to reimplant, if they're pacer dependent, a tried and true method is to use a standard pacer lead that's brought out through the skin, either in the pectoral area or the neck in the internal jugular vein. The suture sleeve can be secured to the skin. A re-cleaned pacemaker can be used, and this patient can get out of bed. It's an extraordinarily stable system, just like a permanent pacemaker, and it can be covered up so that the nursing staff or nobody kind of messes with your work, and this can stay in for days and days. And there are lots of publications looking at this technique of externalized pacemaker as a bridge for pacer-dependent patients. As I said, it can be done from the neck or from the axillary or subclavian vein. In this one study published in 2021, they had patients as short as 2 days and as many as 70 days having this system in place until a new permanent device could be placed. And there's a very, very low risk of lead dislodgement or infection related to this technique. In terms of same-day implantation of an epicardial pacemaker, that is another option to consider when you talk to your surgeons and think about the patient's future infection risk and device options. This study looked at 80 patients who had this approach of an externalized pacemaker followed by permanent contralateral device implant, and another 80 patients who actually had the surgeons put in an epicardial pacemaker on the same day as extraction. In fact, in that latter group, more of those patients had bloodstream infection, 65%. In none of these patients with each of these strategies was there recurrent infection. So this has shown in this case series that implanting an epicardial out of the bloodstream system on the same day as extraction can actually work very well. Those patients, of course, had a higher complication rate related to cardiac surgery, but they had a shorter length of stay because you got a new permanent device in them right away. We published a small series of patients where we did put in transvenous systems on the same day as extraction in a very carefully selected population. These were specifically patients who just had a local pocket erosion or infection, no positive blood cultures. We used during the procedure, as you do, temporary femoral pacing, and then we re-cleaned the opposite side of the chest, broke down everything, started over again, and put a new permanent device on the contralateral side on the same day. These were all pacer-dependent patients, again, with just local pocket infections, and they all did well with just a 2-week antibiotic course for their local contralateral infection, and we followed them up to an average of 3.5 years, and there were no recurrent infections in that small case series. Leadless pacemakers, as you heard, are perhaps a great way to manage these patients, either temporarily or permanently. So many studies have now been done looking at the infection rates of leadless pacemakers that were put in either concurrently at the time of extraction or soon thereafter, and the results are very good, and that's why this made it into the new guidelines, considering leadless pacemaker implantation as a temporary or even a permanent or intermediate strategy for pacemaker-dependent patients. So in summary, if there's no bacteremia in the first place, you have good options, and you could consider implantation of a device even on the same day or soon thereafter because you just didn't have the infection in the bloodstream, and your risk, therefore, to a new device system is likely very low regardless of timing. But again, level of evidence C, expert consensus says if you're going to implant something back in the bloodstream, wait a minimum of 72 hours, making sure that repeated blood cultures are not growing anything, usually on antimicrobial therapy. And if there are vegetations in place, then you should wait ideally 14 days. Again, this is expert consensus, and I'm sure there are exceptions, and a leadless pacemaker might be a great way to bridge these patients rather than having them sit in the hospital for 2 weeks with a temporary externalized pacemaker. By the way, there are some experiences with discharging patients with an externalized pacemaker system. It's not something I personally have been comfortable with, but there are groups that have done that, and they've had good success with a patient going home with an externalized pacemaker system. And then you can bridge the, as I said, bridge the gap. I just mentioned this. Consider the surgical option, especially in patients with endocarditis and risk for recurrent bacteremia. Getting things out of the bloodstream is important, and a leadless pacemaker may not be the best choice for that population. It's important to plan your reimplant strategy ahead of time so you know what you're going to do and what access sites you have available. And lastly, think of the low lateral thoracic site for axillary vein access and a device pocket on that location on the side if the infraclavicular space is occupied bilaterally. Thank you very much.
Thank you, Dr. Cooper. That was an excellent talk. Our next speaker is Dr. Cha from the Mayo Clinic. Dr. Cha is going to talk to us about managing leads in the era of transcatheter tricuspid valve replacement, extraction versus abandonment.
Good morning and thank you. So first, I want to give a brief comment on the etiologies of tricuspid valve regurgitation. And as you can see, the majority of the patient with the tricuspid valve regurgitation are secondary causes. And then 10 to 15% of the patient had the tricuspid valve regurgitation because of the transvenous lead involvement. So this is the second common reason. And actually the primary tricuspid valve regurgitation due to valvular disease is the minority, only about 5%. I want to mention this, this year published a new study, actually is from the Mayo Clinic Echo Division. So this multi-center Mayo Clinic study showed that 13,000 patients who had moderate or severe TR. And then as you can see, the etiology, 90% patient secondary TR. And of course, among these 90%, as you can see the causes here, cardiomyopathy, left side valvular disease, pulmonary hypertension, as you're familiar with. But the one thing I will draw your attention, atrial fibrillation. 22% of these patients, atrial fibrillation is the cause of severe TR. So when we manage a patient with atrial fibrillation rhythm and rate control, this is something taught me from this paper. And the 7% patient had a lead-related TR, and the 3% patient had primary valvular disease. So another interesting finding from this study, and as you can see, the patient with the primary TR actually had a better 10-year survival compared to the patient with the secondary TR and the lead-related TR. So because of the scope of the severe tricuspid valve regurgitation, the patient is highly symptomatic with a heart failure. And in the past, it's always a surgical approach, right, with the tricuspid valve repair or replacement. So now we have a few options with the transcatheter tricuspid valve repair or replacement. So this is the Edward Evoke device. It's the first transcatheter tricuspid valve replacement device, and the FDA approved 2 years ago. And that's a self-expanding nitinol metal frame with the bovine pericardial tissue valve. And then this is the tri-clip transcatheter edge-to-edge repair, called the TEER system. It's the same year approved by the FDA, and then this is a different approach. That's only a repair, but not replacement. So what's the difference between the two kind of devices? And then the TEER device only can achieve a modest tricuspid valve regurgitation reduction. And then, of course, it does not gel the lead. And then the TTVR and has the most effective reduction in terms of tricuspid valve regurgitation. But the downside is the risk of gelling the lead because the device has to be completely anchored at the tricuspid annulus. So there are a few studies because we only have 2 years after FDA approval for the either TEER device or transcatheter valve replacement. So the main focus is the TTVR device. So this is the TriPlace registry, including 20 centers and 395 patients. And of these patients, as you can see on the right side, 291 patients had no CRED lead. But on the left side, about a quarter of the patients did have the the device lead gelled. They did almost 2 years follow-up. As you can see, 5.8% of patients had RV lead failure. And in addition, the study found the gelled CRED lead group had a higher rate of moderate or greater paravalvular leaking compared to the no lead group. So apparently probably related to the lead gelling as well. This is another registry including 329 patients. And I just follow quickly down to here. The focus is these 28 patients with the trapped right ventricular lead. 3 of them had either RV lead dislodgement or RV lead failure at the follow-up. So it's about 10% patient had lead event. Another study included 52 patients with RV lead entrapped by Evoke device. Of these patients, 4 patients or 7.7% had the lead-related lead complications, including lead dislodgement, ICD lead fracture in 6 and 8 weeks after the TTVR, and 1 patient had a serious infection. The last study I want to mention is from Emory Medical Center, Dr. Al-Shami's group. So they did the TTVR in a total of 73 patients. And of these, 52 patients had no pacing lead, but 19 patients had the lead across the tricuspid valve. And of these 19 patients, 5 underwent the lead extraction first, and then the TTVR device was placed. These patients had no complications. The other 14 patients, because of the high risk, they had a lead gelling. And of these 14 patients, 2 patients had a lead fracture. And the 1 patient died in 7 days. So the event rate of these 14 patients is not low, right? It's about 15 to 20%. So you can see the ballpark of the lead event due to the lead gelling is between 5 higher to 15 to 20%, but the majority is at 5 to 10%. So with that in mind, I think currently in clinical practice, it's really it's a significant issue. How are we going to manage the lead at the time we the patient need a TTVR. So that require a multi-specialty team to be involved to discuss, how do we want to manage each individual patient. I think in the past, during the IDE study for the TTVR device, interventionalists probably just do the procedure, and then now they kind of know, the EP side. So we need to address the lead. It's an important issue. So we really need a shared decision making with the patient about should we do the lead extraction, then place the device, or we just go ahead gel the lead. So we need to weigh the benefit and the lead extraction complications. So think about the 4 or 5% or 10% of the gelling lead consequence, and think about the lead extraction, probably in the experience center, 1% mortality rate. So we need to balance the lead age, the number of the leads, patient comorbidities, previous CV surgery, and the lead extraction. Do you have a CV surgeon backup? We have a surgeon here. So if the CV surgeon said it's a too high risk for me to back up this patient, then probably we have to gel the lead. So this is something we have to keep in mind and before we proceed with the TTVR. And also, before the lead extraction, we have to think about what kind of a device we want to offer to the patient. Is a CS lead placement, epicardial lead placement, or leadless pacing. So all these need to be considered. So in summary, the TTVR has evolved as an effective and alternative treatment to surgical valve replacement, and can result RV lead entrapment between the valve and the device. So in patients with the transvenous lead crossing the tricuspid valve and planned TTVR, so the current recommendation is to consider lead extraction, and if the benefit outweigh the procedure risks, to avoid lead entrapment. Thank you.
Thank you so much for that excellent talk. Next up, we have Dr. Henriksen, who's going to be talking about adapting pacing techniques in patients with TTVR.
Great. Thank you for the opportunity to be here. Got it. Thank you. All right. Great. Thanks for the opportunity. I'll be talking about adapting pacing techniques in patients with TTVR. There's a little overlap between mine and Dr. Cha's talk, but maybe that'll make the last talk go a little quicker. All right, I have no disclosures. So for pacing after TTVR, the scope of the talk is really a patient who's recently undergone a TTVR and now has evidence of AV block and needs a pacer for either for V pacing or for AV synchrony. Broadly speaking, there are three choices, realistic choices in my mind. One is leadless pacing, one is a transvenous system without an RV lead, or putting a lead through the new valve, which we all try to avoid. There are other choices that have come up here, like a epicardial lead. I think that's kind of unrealistic if a patient just underwent a transcatheter valve procedure to then do a thoracotomy or a sternotomy. I am not an expert on the various kinds of TTVRs, but I like this slide, even though it's from a few years ago, that there are everybody who makes valves trying to come up with a solution here. And so again, this is from a few years ago, so some of these have fallen by the wayside. The one that we heard a little bit about on the last talk is the Evoke. That's the Intrepid, which is a Medtronic that's under clinical trials that I'll talk about a little bit more. But what all of them have in common is some kind of a stent-like structure that's going to put pressure on the AV node, leaving out these last couple. And with a wide variety of systems here. And so from our point of view of getting a lead through there or the leadless delivery system, each one comes with its own challenges. So how common is this problem? We heard a little bit about that on the last talk. This is also from the TriPlace registry, looking at the 185 patients who did not have a device to start with, and about 13.5% ended up with a new high-degree AV block. And for those, there's some risk factors that you'd expect that we can look at on the next slide, but certainly any left-sided conduction disease would be a risk factor for high-degree or complete heart block. And the management in this population was kind of split between the three options, kind of half leadless pacing and then some RV sparing pacing along with leads through the valve. So this is from that same TriPlace paper. I like this figure because you have your baseline conduction system disease or lack thereof and where the patients ended up. The post-TTVR is as an inpatient while they're still in the hospital, then at 1 month follow-up. And you see, a pretty good path here from normal pre to normal after the valve, and then you're in high-degree heart block when you come back. And these are the similar numbers. Most of the studies are between 13 to 25%. And those are almost certainly dependent on the different kind of valves. And so we're lumping them all together here, but it's important to keep in mind that as we go through this, they're probably going to end up with some which have more heart block than others, which we're all familiar with by extension from TAVR. So a little bit of data. We heard a little bit about this. This is from one center site at Emory. These are all Evoke valves. 14 of the 55 patients had heart block. Most identified while an inpatient, one on mobile Holter afterwards, and 2 who presented back with syncope. Almost everybody got a leadless pacer. One with got a left bundle lead, which would be a challenge in these patients, and one with a CS. No procedural complications from pacer implant. And again, this comes up. They saw a mean of 26 hours, where presumably patients were still in the hospital, but going out to longer than that. So I wanted to go over a couple of quick cases. First one is with an Evoke valve. We heard a little bit about this in the earlier talk, but it's put in this orientation from getting a lead into it or delivering anything through the valve. It's a little scary because it's got these pointy struts pointing at you, which, at least in theory, should be easy to catch on and cause a problem. The slight, from an EP point of view, unrealistic diagram here is that there's no pressure on the AV node at all. So you'd think it shouldn't cause AV block. So this was a 68-year-old guy, permanent AFib, severe symptomatic TR, underwent TTVR, did have a baseline right bundle branch block, unremarkable implant of the TTVR, discharged post-op day 3 with an ambulatory monitor, then reported some fatigue and shortness of breath, and was found to have an intermittent complete heart block, and during those times had escape rhythm in the 30s. He was admitted on post-op day 9 to get an urgent pacer. And in terms of decision-making for him, his EF was normal, and our choice was really, we want to avoid a lead going across the valve. So choice is really leadless versus a lead in the CS. And certainly with a kind of intermittent heart block and and normal EF, leadless seemed to be the way to go. Here. Yeah, so when I do these to get something through the valve, we have the luxury of having biplane, which is definitely the way to go on these, and you line up everything as clearly as you can. You make your LAO right down the barrel of the valve, and the RAO orthogonal to the valve, and very carefully go through the valve. I try to get the leadless into place as kind of with a little futzing as possible. I do worry about harming the valve with the great big delivery sheath. This one turned out to be fairly straightforward, and I ended up with the device in, and you can see the valve. So that was reasonably straightforward. We also OHSU is part of the clinical trial with the Intrepid bioprosthesis. This is what the valve looks like. It's also true for the Evoke, but perhaps more so for this. These valves, the biggest pressure that they get and where you worry about them dislodging is during ventricular systole. So they're very in tuned in the design to keep the RV from ejecting it into the RA. They're not so worried about it dislodging from the RA to the RV because that's against the pressure gradient. However, that means they're not designed to have especially like a leadless catheter poke up against them. And so this is a 42-year-old with Epstein's and a distant surgical tricuspid valve repair who underwent a TTVR. Also, the procedure went smoothly. Returned to the hospital with presyncope, was found to have episodes of complete heart block. His valve was about a week before. So this again was one where we were trying to decide what the best pacing option would be for him. And we again ended up doing leadless for a couple of reasons. One was, again, a preserved EF. And two was getting into the CS in patients like this. This valve does not cover the CS, but getting in, you can't use the typical techniques to get in because of the valve, and it's kind of more messing around potentially than putting a leadless through. So again, these are stills, but biplane, lined up well. Really want to make sure you are confident in what you're doing and not catch the edge of anything. And it makes its way through the valve carefully, watching the whole way in two planes. Yeah, for this, I was really sensitive to manipulating the catheter a lot because the valve team was not confident of the stability of the valve, frankly. So we got into a place, as you can see, that's not an ideal place for a leadless device, but there's a prior sternotomy. That's where we could go. And so that ended up being in a slightly atypical position, but worked well. And then we were very worried about dislodging the valve, obviously, but we did okay, and you can see that the atrium, and this is not dislodged towards the A or too far into the B, so we're happy with that. Good. And that's what we ended up with. It was a dual chamber leadless, obviously. All right. So in conclusion, we have a lot of choices in pacing these days, and it's certainly a goal to avoid placing anything permanent across the new TTVR, certainly in the best interest of the valve, best interest of the patient. I think lots of communication with the valve team around these patients, as everybody else has alluded to, and really understanding the valve and what the potential dislodgement risks are. All right. Thank you.
Thank you, Dr. Hendrickson. So, question for you from the audience. Any comments on type of leadless, and does atrial mechanic sensors catch the AV closure to maintain AV sequencing?
Boy, that is a great question. Both of these cases were AVEIRs. In terms of the micro AV, I think either one, the delivery system is similar enough that I don't think I'd have a strong preference for either one. I don't know, maybe somebody on the panel knows about how well the atrial sensing works on an AV with a valve in place. I mean, I assume it would still work, but I can't vouch for that.
The only reason I sometimes favor micro-AVs is the length.
Yeah, good point.
Away as I can from the valve. To be honest, I don't have a lot of experience in the AV synchrony, the big valve. I'm assuming most of these, the atria barely function anyway, especially the Epstein issue.
Fair enough.
Do you have a comment about the transjugular approach for example, the three-clip tricuspid occlusion compared to femoral approach, especially in the AVEIR pacemaker, which have the big deflection compared to Micra? A comment, please.
Yeah, I guess I can't comment from a place of knowledge. I have not put any from the neck. I don't know if anybody else has comments. It seems like a straighter shot and may make sense. So far, I've done them all from the groin.
Yeah, sometimes from the neck it's easier, especially the bigger valve, like the interpid valve, because when you come from the groin, and if the valve is very long, trying to direct to the septum, sometimes it's challenging. You have to take atypical location, like an apex or. So I've used the IJ approach, and often it's easier with those.
And we also use the subclavian approach, especially from the left side. So it's to follow the device implant curvature. And then it's very doable. So it's not very difficult, let's put this way. So
Atrial might be a little challenging to come from the jugular curve, but you don't have to worry about it because you're not crossing the valve for implants.
Just a couple quick questions about other options. And about the pacing from the CS only, if you're pacing from the lateral, a lot of people have RV dysfunction going into these pulmonary hypertensions. Any thoughts of the thought of left bundle branch block or RV pacing leading to LV dysfunction? If you're pacing only from the CS lateral, would that cause RV dysfunction? Maybe a middle cardiac vein pacing strategy might be a better option?
I guess my initial thought on that is that there are pretty good studies early on in BiV pacing, as I'm sure you know, that showed that kind of lateral CS pacing was just as good as CS plus RV. The RV dysfunction, I mean, in a lot of these patients, the RV's a little shot already. I don't know. That hasn't entered my decision making, but maybe it should.
And perhaps even if you went with BiV from a middle cardiac and a lateral PLV type branch, maybe you get the best of both worlds with a bipolar in.
Yeah, the problem there is that you're trying to resynchronize the right ventricle, so really you'd need a free wall lead. So I don't think that two LV leads would help with RV synchrony in its complex shape. I mean, that would be like putting sort of an RV free wall lead and a septal lead in the RV to help with LV synchrony. It wouldn't work, I don't think. It's a great point.
But maybe MCV will be less dysynchronous than PLV at least from there. And then I think the Houston Methodist group had shown with mechanical tricuspid valves, His bundle pacing, but transatrial His bundle. They had high thresholds, but at least if you needed a 5 to 7 year pacemaker, they drilled through the atrium to capture the His bundle as such, and at least you can still maintain a transvenous system without going across the valve.
The problem here is I think there's such a big collar on the atrial side of the valve. I wonder if it's covering that little key place where you could get to the His, I would think. I'm wondering about, as you were saying, how do you get to the coronary sinus with this large atrial collar, let alone that posterior superior process to try to get to the sort of His area.
Thank you.
Challenging.
I like to have one extra comment on the trying to use the leadless device or CS Actually, I don't think we have experience about if the transvenous lead across the tricuspid valve, is it going to be worse than not cross the tract? We had a study, the patient with the bioprosthetic tricuspid valve placement by surgeon. I think we found about 60 patients. And then we had a control group. It's the same time patient received the transvenous pacing without valve. So just a parallel comparison. Actually, the study did not show the bioprosthetic valve with the cross tricuspid valve lead had the worst valve dysfunction at all from our study. So this is a new area. I think we need to probably group together to look for if the cross valve lead does do much more harm than the natural valve.
Sure.
Yeah, so this is something we don't know because it's a new transcatheter valve. Yeah.
Thank you.
I guess there is some concern about thrombosis. This is what I hear from our structural colleagues.
Yes, that is another good point.
Yeah.
Because that valve,
Right.
yeah, does have a thrombus issue.
Lots of questions, but I am curious and want to hear from the speakers. In the patient who has a BIVICD or someone who needs a defibrillator, how are you approaching that patient? Leadless with the sub-QICD does not seem very appealing. So how are you guys approaching these patients who need a TTVR?
We published our experience putting ICD leads down the MCV, and it's hard. It's a challenge. You have to use a Worley sheath, or maybe there's some other big sheaths out there, and if you can get a wire in there, you have a good chance. It can go in a posterior lateral branch as well. It could even sit in the main body of the CS. It's pretty stable. So we found the DFTs to be absolutely fine. You cannot count on that to pace, though. Sometimes the thresholds are high, so you sometimes have to use yet another CS lead. You have to use a DF1 ICD lead. It's a challenge, but if you really want to end up with a percutaneous BIVICD, you can do that, and you could also put a epicardial surgical BIVICD, as you showed in heart rhythm last year. That's a big deal as well. That's a full sternotomy, but they're fully functioning systems, and you could refer that paper to your local surgeon if they think it's not a good idea, because it's quite straightforward.
You can also put a 7 French, I've done on 2 occasions, a 7 French ICD lead, the Dorada, down the middle cardiac vein, and that can go through a sort of a CS access platform. You don't necessarily need the Worley sheath because it's a smaller lead.
Do you have issues with sensing?
Yeah, on the occasions I've done that, the sensing and pacing from that lead were poor.
Yeah.
And so you needed sort of another CS lead going down a lateral branch to serve for, and a bipolar lead, and obviously a DF1 system. So you kind of rig it so that other LV lead is the one for pacing and sensing.
Well, thank you to our speakers for sharing their expertise in some amazing cases and an engaging discussion. We really appreciate it.
Thank you.
Thank you, everyone.
Yeah, it was.